Welcome to another episode of Discussions with Dr. G. I'm Dr. G, your slightly sarcastic, cat-loving nurse educator, talking today about a topic I promise is more exciting than it sounds: how policies and systems shape community health. Now, before you roll your eyes, I've got to say, if you think health policy is just for politicians with too many letters after their name, you're going to miss how big an impact this stuff has on your everyday nursing gig. So let's set the scene. The mission of public health: deliver quality, equitable care with communities, not just as patients, but as, actual participants. That means we focus a lot, sometimes obsessively, on prevention, wellness, and measuring those population outcomes. But here's the sneaky bit. Policy is like the invisible hand behind the curtain. Federal, state, local rules. Stuff like Medicare, Medicaid, or your city's immunization program. That changes how, where, and even if your patients get care. So think about it. You're a nurse in the real world trying to keep a neighborhood healthy. At the federal level, Medicare and Medicaid set the standard for elderly or low-income care. State governments wrangle with insurance rules and professional licenses, and local policymakers decide if that water safety upgrade means no more boil water notices for grandma. Oh, and don't get me started on the private sector. Insurance companies and hospital systems want to innovate, create shiny apps, or roll out specialty programs, but they're also laser focused on profit. That means, you get innovation and sometimes great coverage, but also rising costs and, surprise, gaps in who gets what. I always compare the public sector with its broad, we'll cover everyone approach, but it can get bogged down in paperwork and bureaucracy. I've seen Medicaid applications longer than my last yarn shopping spree. Meanwhile, the private sector wins on slick ideas, but trips over its own shoelaces when it comes to who can actually pay. If you think all we do as nurses is follow doctors' orders, surprise! Turns out we're expected to be advocates too. Actually, the heart of nursing in the community is spotting gaps, raising your hand and saying, hey, maybe we could do better. Think about Lillian Mauld, Florence Nightingale. Those names you keep hearing in school. They were literal legends in advocacy, pushing for reforms when doing so was both revolutionary and, probably very exhausting. So how does that play out now? You're assessing your community's needs, sometimes with fancy survey tools, sometimes just by listening. Then you plan interventions that actually make sense. You implement, and you always evaluate whether what you did made life better for your patients. To be effective, you got to know what policies are out there. Otherwise, it's like showing up to a potluck with only napkins. Policy awareness isn't just nice, it's necessary for advocacy. So what does getting involved look like? Honestly, sometimes it's glorified chaos. Imagine you are at your very first local health coalition meeting. You barely go in to understand what anyone is saying, because every third word is going to be some policy acronym. Think someone dumping alphabet soup on the agenda. Meanwhile, you're sitting there, stress crocheting a scarf that ends up 5 feet long because you're so nervous. Regardless, you stay and you learn the terms, and you get to see nurses actually push for better mental health resources in your area. And you can bet your scarf will get a lot of attention by the time the debate really heats up. And it isn't just about attending meetings. Advocacy includes working through coalitions, joining forces with organizations like the American Nurses Associations, and even talking to legislators. Systems thinking, that's your best friend here. You see the connections, spot where you can nudge the system to make things better for the population instead of just slapping band-aids on problems. Now, let's get to the unsung villain: money. Resource allocation in healthcare is like trying to bake a cake with half the ingredients. You constantly face funding constraints, tough choices, and sometimes ethical dilemmas that make your head spin. You ever hear the utilitarian principle? Basically, it means trying to do the greatest good for the greatest number, which is noble, but can feel really unfair if you're the one left out when staffing shortages hit. Economic models decide who gets what care. Things like DRGs, or diagnosis-related groups. That's how hospitals get paid for specific cases, and health savings accounts let folks save for care. But who even has enough left over at the end of the month? You've got public programs like Medicare and Medicaid, and CHIP, the Children's Health Insurance Program. And here, CHIP is a great example. Its expansion meant kids in rural towns who never had regular checkups suddenly could see a doctor, get asthma meds, and all that good stuff. But here's where it gets tough. When budgets are tight, and trust me, they're almost always tight, somebody has to decide where the money, supplies, and staff go. And sometimes you're the nurse in the middle of the triage situation making that call. Teaching my students about this is always kind of stressful because it's not just theory. It's who gets the last bed, who gets the last flu shot, who gets the last hour of your shift. You have to weigh justice, beneficence, and real-world limits all at once. So, to wrap this up, at least for now, community health nursing is about using the big picture. You advocate, you know your policies, and you make the tough calls. The work is never truly done, but that's what makes it meaningful and, honestly, kind of addicting. Next time, we'll dig even deeper into the day-to-day challenges you'll face as new nurses out there. Until then, don't let your cat delete your notes, and definitely finish your scarves before the next meeting. Until next time.